Hello, my name is Tasnim Anika, and today I am interviewing Dr. Ruhul Abid. A physician scientist with MD PhD degrees, Dr. Abid is a professor and principal investigator of the Cardiovascular and Global Health Research Lab at Brown University. He is also the president and founder of HAEFA, or Health and Education for All, a nonprofit global health program that provides free healthcare services to underserved factory workers in Bangladesh and Rohingya refugees from Myanmar. Recently, he has been nominated for the Nobel Peace Prize. Congratulations to the nomination, and thank you so much for joining us.
Thank you. I'm very glad to be here. Thank you, Tasnim.
Thank you. As someone with extensive experience working in Bangladesh and the United States, how would you describe the healthcare challenges that South Asians are currently facing?
South Asians are actually facing the current situation is the global pandemic. So this global pandemic, if we take that into consideration, which is very much like widespread around the globe. So South Asia is part of that. But given the structure, given the health infrastructure, population density, and other geographical situations, they are facing quite a bit of challenge for this COVID-19 because since the developing country structure, healthcare is not, as you know, that it's not the best or not very powerful health infrastructure is there. And also the people's like socioeconomic conditions, because many people cannot work just remotely, which is possible in the Western world. So they have to be in the field, on the ground to many work is like that. So majority of the population, either agriculture or like a manufacturing, like a ready-made garments factories and all those kind of things. So they have to be on the ground and daily laborers. I think the South Asians in general is more prone to exposure of this global pandemic at this point because they are on the ground and in the field, as I mentioned. So they are more prone to other places where they can be remotely working and mostly like a home quarantine or isolated themselves or so-called lockdown of the whole system. So I think the challenges are more there in South Asia.
So in the context of the global pandemic, you would say that it's hit South Asia more severely than some of the other countries, correct?
I think yes, because of the nature of this. Maybe we are not seeing the severe outcome and other things. Those are kind of a consideration of the virus strains and other considerations like some genetic changes or epigenetic changes in the population. But in general, I think it's a hard hit in South Asia compared to other places because the socioeconomic condition and the developing nature of the countries, like the economies.
Thank you, Dr. Abid. So before the pandemic, was the situation in South Asia roughly the same? How did they fare before the coronavirus hit?
Before the coronavirus hit, it was kind of as like a South Asian countries. There are different country has kind of different kind of structure. Like as you know that India, Bangladesh, Pakistan, Sri Lanka, Nepal, those South Asian countries have kind of different economic situations a little bit and the infrastructure also. So before pandemic, I think they were doing, compared to their socioeconomic conditions and geographical situation and all those geopolitical situations, they were not doing bad, but there are deep pockets of inefficiency in the healthcare system, which actually this coronavirus brought out more kind of severely because the lack of a general health insurance system in South Asia in general is a weakness because most of the people are dependent either on the government system, healthcare system, which is very minimal or not sufficient, and private healthcare system. So private healthcare systems servicing the upper and middle class. But when you go to the lower strata of the society, so socioeconomically, you find them like mostly dependent on the government healthcare system, which is not sufficient, as I mentioned. And then unless they get like a kind of a severely ill or something like that, they do not seek healthcare because of the they cannot afford the private system. So, and the government system is mostly geared towards the tertiary care where there is kind of a severe illness only for that. So there are some places like in some countries, especially in Bangladesh, since I'm originally from there, so I know a little bit better about Bangladesh than other countries. But so there are like some remote government centers are there, like in the villages, community clinic and all those. So before pandemic, they were doing good in the villages there, but once they are coming to the urban system, or like urban healthcare system, the people who live in slum, they always remain kind of outside the healthcare system, because they are kind of dislodged from their roots in the villages where they have some kind of public health. But in the urban system, it's mostly private healthcare.
So you would say also for the coronavirus, it has disproportionately affected the lower class in society for South Asia, correct?
Very much so, very much so. The workers, migrant workers from one place to another, they got hardly hit. Like in Bangladesh, Rohingya, Bangladesh garment factory workers, rickshaw pullers who are daily laborers live in slum. Same for India also. Like because India is a large country, they have like migrant workers from one state to another, or one province to another province. So they also got a huge hit, because they had to come back after walking miles and miles from one state to another, because there was a shutdown of the transport system, lockdown of everything, shutdown of the factories. So they were really, really hard hit.
Right. Thank you, Dr. Abid. That's very insightful because I am also from Bangladesh. So that's very interesting to learn about, especially coming from you. So you also had the opportunities to visit and provide health and education services in Rohingya refugee camps in Bangladesh. Could you tell us about what motivated you to provide these services to the refugees and about your experience on the ground?
So actually, when since 2013, Health and Education for All actually has been providing healthcare services to the underprivileged and underserved people in Bangladesh. So we are doing the work in Bangladesh. Mostly it's not because like we are from Bangladesh, but we have easy access to do that in that country, since I'm originally from there. But now we are expanding on other places also, like trying to do in other countries like Nepal, Thailand, and Syrian refugees, all those. But your main question is like what motivated me. So since we have been there on the ground in Bangladesh, like since 2013, doing a lot of work, like primary health care for the industrial workers, then underserved, displaced people, cervical cancer screening in remote places in Bangladesh, like a Chor, or like a people who lost their lands due to say storm or cyclone or flood. So they live in a kind of a small island called Chor. So we are pretty much present there. But in 2017, when this big, or the latest exodus, this is actually the fifth largest exodus of Rohingya refugees from Myanmar. This is not the first one. This is the worst one actually. So that happened. So I was in Boston and I saw the news on news media, and I got so kind of shocked and so kind of overwhelmed with the whole situation, that how come like people can do something like this to another group of people, and then their sufferings and all those, and saw that they are coming through the like paddy fields, the rice fields, and crossing the river, the Naf river in between Bangladesh and Myanmar, and they are suffering. So that actually kind of motivated me that we have to do something for them.
Right. Thank you. Can you name one situation that you experienced working at the camps? What struck out to you or what affected you when you were helping the Rohingya refugees?
There are many. Like in the beginning, as you know, that 25th of August 2017, these Rohingya refugees were coming to Bangladesh in
Right.
first, like during this latest exodus. And that time, actually, you know that they were like sexually assaulted, they were killed, they were raped, they were children were burnt in front of them. So it's a devastating situation. So the first time I was on the ground there, because our camp, the two medical centers there, Kutupalong and Balukhali, they started treating patients since on I think on October 9th 2017. And myself and Professor Jane Carter, another professor from Brown University, she's actually the at that point she was president of the International Tuberculosis Union. So since my expertise is cardiovascular and non-communicable disease, hypertension, diabetes, and she's in tuberculosis, so we went together to the camp and visited two of our medical centers in October 2017. And that time there were still people coming. So the first 4 weeks since 2000, since 25th of August 2017 were the major exodus, but then they kept on coming until like October, November. So the day we arrived there, we saw a small group of people, like 20 to 25, and out of them, like at least 3 women told us that they were sexually assaulted. And some men, we saw a gunshot wound. So those are kind of a very difficult situation for us to see that first time, like firsthand. And then in the long run, later, at one point, I have been visiting the camps like every 2, 3 months for since 2017. So just COVID-19 for the last 8 months, I could not be there physically, but my team has been working both the clinicals. So in 2007, 18 actually, I met a girl who looked like maybe 8 or 9 years old, but later we found that she's 16 years old in 2018. And then she brought a lot of prescriptions with her. She had been examined for AIDS, like HIV virus, tuberculosis, and hepatitis C and whatnot, all the severe kind of diseases, even for cancer, whether she has cancer or not. But since our medical centers routinely does like check blood pressure and blood glucose of every patient from the beginning, so we found that she was a diabetic, a juvenile diabetes case, type 1 diabetes. And that's why she was chronically ill, and like a growth was kind of retarded at that point, so slow growth. So then we started treating her, and now every time I go there, she comes to visit me, meet me, and then she takes picture with the whole camp people, and she's getting medicines every week for diabetes. So now she looks like she's now 18, but she looks like maybe 14-year old. So but she developed a little bit. And the striking thing was, she told us in 2018 when we first diagnosed her that she had a twin sister who just passed away maybe a month ago before she came to our center. So that made us, and she had similar conditions. So maybe she was undiagnosed with the same condition. So that really kind of stayed with me, that experience, that this is like kind of a life-changing event for some people. And if we could do it a little earlier, we could save another life.
Right. Thank you. Thank you very much. To go off on that, according to the United Nations Refugee Agency, on average, a refugee spends 17 years of his or her life in exile. How do the Rohingya refugees fit into the South Asian healthcare system as a whole?
So the Rohingya refugee, you are right that average encampment is 17 years, because earlier Rohingya refugees came since 1980s, 1990s in Bangladesh, like 200,000, 300,000, and then they repatriated maybe 50% of them. 50% of them either went to different countries, Saudi Arabia, Malaysia, Indonesia, and some remained in Bangladesh. Because before this latest exodus in 2017, there were at least 200 to 300,000 Rohingya refugees in Bangladesh, actually, that point, near that border, because they could never return or could not go to another countries. Because this is not the first time. These persecutions, as you know, that this UN actually defined them as the most persecuted minorities in the world. So it has been going on for decades, like 1978 they first started, and 1970s actually. So then in 1982, Myanmar military government, General Ne Win was in power that time. They actually stripped of their citizenship, Myanmar nationality. So since 1982, they do not have any health care. Like they did not receive any immunizations, any vaccinations, which are accessible by every citizen in the world. So they were without that. Can you imagine a whole population, more than 1 million people, have been without any immunization for 40 or 50 years. So when they entered Bangladesh, this latest exodus, like they were without those vaccines. So initially, Bangladesh government actually did an excellent job, like deforested the land there to make space for them. Because, you know, Bangladesh is one of the most densely populated
Yes.
country in the world. So they did not have any extra space. So they had to deforest. They had to did a lot of I would say, damage to the environment to protect this persecuted population. And then they built the makeshift camps. So initially when we went there, we saw like polio measles outbreak, but Bangladesh was almost free for polio and measles, free of polio and measles, because immunization was very successful in Bangladesh, because Bangladesh health infrastructure, healthcare for public health is very strong. So they were kind of immunized, the whole population. But that their polio measles outbreak, then Bangladesh government, Ministry of Health, and a lot of international organizations, including our organization, HAEFA, Health and Education for All, we all participated in immunization program, and that actually helped to prevent the outbreak of polio and measles. But then they had diphtheria. That was the most contagious disease. So that was also controlled. So I think Rohingya is a unique example. They do not fit any healthcare system in South Asian countries or in the world, because they have been without vaccinations for 40, 50 years because of this persecution within their own country, because they were stripped of their citizenship. So now they are receiving healthcare through the Ministry of Health, the Bangladesh government, and international organizations like ours, then WHO, UNICEF, every organization is helping there. So, but they are still not the part of the main system of the healthcare in Bangladesh or in any country.
So because they were not able to receive any type of immunizations, you would say that mostly they were plagued with infectious diseases rather than non-infectious, or did you see equal amounts of both?
Oh, that's a very good question, because the infectious disease, yes, it's true that they had this polio, measles, diphtheria, all those, but you can vaccinate and you can prevent. So that's one thing. So they were more prone to that. But due to this long persecution and without any, they were not receiving any systematic health care for 40, 50 years. So couple of generations actually. So they had a lot of non-communicable disease at this point, because our main expertise is non-communicable disease. Though we do passive screening for tuberculosis, we take care of pregnant mother, but that hypertension and diabetes, you'll be surprised to hear that they have a pretty high rate of hypertension and diabetes in that population. And we are actually analyzing the data and publish a paper on that. So there we'll see how much is that the prevalence. But and the malnutrition is very prevalent among the children, because of their situation for generations. So yes, I would say infectious, non-infectious, they are more kind of prone to both.
Mm. Would one part that contributes to that be the fact that the settlements are very overcrowded? Sometimes you don't have room for all of the refugees?
For current situation, if you think that the current situation, because this non-communicable disease, hypertension, they take years to develop.
Right.
So I think it's mostly their lack of healthcare, lack of food, nutrition, their stress of this living in a kind of in your own country for 40, 50 years like that. So those are the maybe contributing factors, lack of food, nutrition, health, education. Their education was also kind of they were deprived of education there while they were in still Myanmar. So in the current situation in the Rohingya refugee camps, yes, they are densely populated, because in 5,000 acre area or around that, there is like almost 1.1 million people living in. So it's 6 times more densely populated than New York City. So it's like it's very densely populated. So in one kind of a room, maybe 4 to 5 members of one family, because they have 3, 4 children and a couple. So on average, 5 to 6 people living in one, say 8 foot by 10 foot kind of a makeshift camp or shelter. So the densely population make them more vulnerable to infectious disease and all those. So like skin disease is very prevalent. There may be lung disease. So now the COVID-19 can, if it's, so far it's not like hardly hit, but they're already there. 9 deaths are there. Already 9 deaths are reported, and like around 300 cases positive of COVID-19. But if it's spread there, it would be like really kind of a disastrous situation for this dense population.
Right. In your experience, did you find treating the non-communicable diseases harder because they develop over many years?
Non-communicable disease treatment is harder than any communicable disease, because communicable disease you have to give them, say for either you isolate them, quarantine them, and give a treatment, say for 7 to uh, 14 days antibiotic for any infection. Or if it's a fungal infection, then maybe a little longer. If it's tuberculosis, it's 6 months. But as you know, That's a very good question, actually. So as you know that non-communicable disease is a like kind of a lifelong situation, mostly. In most cases, hypertension, diabetes, there is no cure. You can just manage. And that management has to be sustained and prolonged and regular basis. So non-communicable disease is not only difficult in Rohingya camp, everywhere in the world, because you need a chronic, like a continuous follow-up. So every week measurement or a monthly checkup and taking the medication regularly. In Rohingya refugee camps, it's very, very difficult. So probably we are one of the few or probably the only organization in Rohingya refugee camps who are able to do like a good care of non-communicable disease, because we have a very unique electronic medical record system, which we developed in 2016 while we were treating the ready-made garment factory workers and other populations in Bangladesh. So we developed that, and then we took it to the Rohingya refugee camp in 2017, where there was no electricity, no internet. So what then we improvised that electronic medical record system. It's a handheld, portable, individualized medical record system. You can use handheld tabs and a laptop. So we did that. We improvised that solar power instead of electricity. So solar powered electronic medical record system is there, and we actually overcome the problem of not having internet with a local Wi-Fi router, which is connecting all the tabs for the healthcare workers, doctors, nurses through a laptop in the medical center. So, and then we provide a digital barcoded health card to every patient comes to our clinic. So, and then when they come back every week for non-communicable disease, hypertension, diabetes, they come every week to our medical centers, get medicines, get checked for blood glucose, for hypertension, blood pressure. And that's how we keep the record. And so any patient coming for last 1 year or 3 years, you just with a one click or one scanning of his or her digital health card, you can retrieve all the previous data. And that's the uniqueness of our HAEFA's medical centers in Kutupalong and Balukhali. And that's how we are actually providing very good care. And not only there, from other camps, from other organizations, they also refer their non-communicable patients like hypertension, diabetic cases to our centers. So that's how we are best equipped and best situated for doing that. But mostly it's a very difficult, and it's the most difficult actually management in any any refugee situation or displaced populations.
Mm-hmm. You are referring to Nirok, right? If I'm pronouncing that correctly.
Yes.
Yeah, very interesting. I was reading a lot about it, and it sounded like something completely new. And I was also going to ask you how you provided healthcare while there's not many resources, like as you mentioned, electricity, but then you've already answered that question. So thank you. Um, Also, just going back to you were talking about Bangladesh's healthcare policy towards the Rohingya. So, are there any policies that have created barriers in providing healthcare for the Rohingya, and how do you think they can be dealt with?
Actually, I would say that in general, Bangladesh Ministry of Health or the Bangladesh government uh, actually did an excellent work. So in general, because when they came without any vaccines and anything, Bangladesh provided them the shelter, then quickly mobilized their health care and their resources, healthcare resources to the camps, and organized an international group and invited international groups like IOM, UNHCR, WHO, UNICEF, and they formed a coordination cell. HAEFA, our organization, is also part of that coordination cell, and so it's a coordinated healthcare system there.
Mhm.
So if I just give you an example, because though I work at Brown University, but I live in Boston, so Boston is kind of one of the best cities. I would say that they have the strongest healthcare system, one of the strongest healthcare system, and then education and everything. And the in general population is 500,000 to 600,000. Just think of if within 4 weeks another 500 or 600,000 people come to Boston who have never been vaccinated, who have never had any kind of treatment system, what would be our health infrastructure here? What would be the general situation? Because you are tilting the balance of herd immunity and everything, because you are bringing unvaccinated, unimmunized, non-immunized people. And in Kutupalong Balukhali, where they came in Ukhia, that sub-district was kind of around 500,000 people or maybe less, 300,000 people, native, like host community were there. And then you brought in like around 1 million people. So that management, actually, I would say that it was very strong management and very efficient, because they prevented, the government and the international organizations like ours combinedly, we prevented at least 3 to 4 epidemics: polio, measles, diphtheria, you name it. And there was no cholera, actually no cholera epidemic, due to this kind of situation, health and hygiene. Cholera, you know that it can be, cholera outbreak is very easy in this kind of situation, but they prevented that with the deep tube well, sanitation and all those. Though sanitation is not great, like one toilet or latrine is used by 20 people or more. One bathing room or the bathroom is used by 40 to 50 people, because different families are there. So the situation is, I would say that it's very well managed there, and Bangladesh government provided full support. The only thing I would say that was a little bit difficult, because the national security or other security purposes, because you know that it's very near to the border with Myanmar. So sort of sensitive reasons and all those, they actually prevented initially the telephone system, like so that mobile network. So during early part of the COVID-19, we had some difficulty to reach the people in the camp with the messages like COVID-19 and protective messages. But that government and other organization overcame using megaphone and Rohingya volunteers going to shelter and announcing. So I would say it's overall, but now the telephone system is open again. And I would say that it's pretty much positive, whatever they are doing, given the resources, given the situation.
Right. Thank you. Also, to add on to that, do you notice any disparities between the healthcare that Rohingya refugees get compared to the healthcare that the general South Asian population or the general Bangladeshi population, the healthcare that they receive?
So the healthcare system in South Asia is pretty, actually, though South Asian countries are kind of socioeconomically kind of similar, or there are common ethnicity in many parts, though it's a very diverse population. So they have different infrastructure or different healthcare capabilities in different countries. Like maybe Sri Lanka has a very good system, and India, being a large country, have mixed systems. Bangladesh, although densely populated and a small country, but still it has a very good rural healthcare system and a good private healthcare system. But only the urban care, as I mentioned, that the general urban healthcare system, which is 36% of the population of Bangladesh, urban healthcare. And then, so that 30, mostly they live in slum and other places. So there, they do not have that healthcare system nicely. So if I compare that, so that's why it's difficult to compare in general with the South Asian healthcare system and the Rohingya refugees healthcare system. But being in a refugee camp, I would say if I compare with the district they're living in, Cox's Bazar, that would be a fairer comparison actually. So the district of Cox's Bazar, which one sub-district, Ukhia, one is Teknaf, those are nearest to the border of Myanmar. Cox's Bazar has 8 sub-districts, so 2 of those are like near, populated by the Rohingya refugees. And so whole Cox's Bazar population is like around 2.2 million. And Rohingya refugees are there 1.1 million around approximately. So, and then the camp healthcare infrastructure is, I would say that it's not so strong because it's a temporary kind of measure. We have like several field hospitals, so not sophisticated hospitals are within the camp. But if there is some referral or something is needed, they can be referred to the nearby district hospital, which is the government Cox's Bazar hospital or the sub-district hospital. So they kind of I'd not say enjoy a facility. They have access to good healthcare system within the camp for general management, but for complicated and further like which require referral, they have the access to the others places in the government system in general Cox's Bazar. But in general, Cox's Bazar healthcare system compared to Dhaka or Chittagong, other healthcare system is not so developed. So I would say comparison of between host community and the Rohingya refugees is kind of a similar healthcare system, I'd say.
Right. Thank you. Also, as stated on Health and Education for All, or HAEFA's website, as of July 2020, your team has provided healthcare for over 145,000 patient visits from Rohingya refugees. In the future, what are some of your long-term and short-term goals you hope to achieve?
Is our main goal. So as you mentioned that we treated 145, now it's more than 150,000 or I think 170,000 around that. So because we are treating every day like 200 to 300 cases in two health centers, around 200 to 300 every day, and then 7,000 to 8,000 patients per month on average since 2017. COVID-19 actually reduced initially the patient inflow to the centers because they were afraid, there are very much stigma and all those. They were afraid to visit any health centers since May, June, July, around that time this year, because they were afraid that they will be isolated, they will be kidnapped. So there are many kind of stigma, because you can understand, like, this population always had some kind of suspicion against any authority, be that government, be that healthcare, because they have been persecuted for decades. So it was difficult at first for them to come, but now they are coming in more. But your question is like, what's the future, or what we want to achieve there? We actually, though we are a health and education for all then by name, and we want to provide health and education, but we want to achieve, actually the long-term goal is to get the human rights back to this population, so that they can have their country, they can have a land from which they were expelled or persecuted, because they have been living there in centuries. So it's like they did not go to Myanmar, actually. Myanmar came to them. If you see their history in 1784, until 1784, they are totally independent Arakan kingdom. So then the Myanmar came to them. So our long-term goal is to give their human rights back and give them homeland. But as a healthcare organization, our long-term goal, or until they achieve that human rights, our long-term goal is to provide them access to quality healthcare, provide them access to good management of all kind of diseases, like for pregnancy checkup, antenatal, non-communicable, communicable disease, and to do a good coordination. Like, as you mentioned, Nirog, our electronic medical record system, the solar powered, we'd like to share it with all other organizations within the camp, so that any center is seeing the patient, they know what this patient has. If a patient going for, say, pregnant childbirth to one hospital, they do not know that they had, whether this patient had gestational diabetes or hypertension during childbirth. So, but if we have that electronic medical record system, NIROG, kind of a digital ecosystem within the camp for all the organizations participating in healthcare, that would be a great achievement for HAEFA, because we can provide then a systematic care and a kind of a continuity of the services.
Thank you so much, Dr. Abid. That concludes our interview. So that's all the time we have. Thank you so much for coming and meeting me. It was very insightful to learn about your organization, HAEFA, and yourself. It was very insightful to learn about all of that, especially coming from you, who has a lot of experience in the field. So thank you so much, and congratulations again on your Nobel Peace Prize nomination.
So thank you, Tasnim. Thank you for your questions and giving me the opportunity to respond to those, and to speak about the conditions of the South Asian health structure, especially of the Rohingya refugees, because as we speak, they do not have any social distancing or any kind of measures there. So we really need to protect this population. And I really appreciate your and your organization's efforts to bring this to the mainstream discussion and motivate the young populations like yourself. So it's really, really refreshing to see this effort. Thank you very much.
Thank you as well.